We're going to talk about disaster management today, and we just want to touch briefly on, you remember learning in community health about disasters and triage, but we're going to take it a little bit further and talk about how then in the community it hits, but then what happens in the emergency room setting as well. So Danny is a lot of knowledge as well in the disaster management, and then we'll touch briefly on hazmat as well.
All right. So talking about disasters, you really got to sit down and think about, what is a disaster? It's really just a time when the systems that are in place are just overwhelmed for whatever period of time or for whatever reason. And you'll see some of the disasters we have dealt with are really not the big dramatic things that you think of a disaster like a tornado or a train accident, but certainly we've had to deal with both of those types of things in the past. And you have to keep in mind when there is an incident going on or a disaster that's going on that you have to keep track and take care of the normal patients that would normally be coming through anyway, so the people who come in with the belly pain or the sprained ankle, those people still need to be taken care of as well as the people that are involved in the incident that's happening. I'm going to talk a little bit about how Riverside has set up their disasters and 3 different levels of disasters that they'll call, and then some subcategories inside of that. So a level 1, when they call that, that's something that's usually mostly handled with the staff that's in-house. It's just that for whatever reason you're expecting it to be a short time, that there's a surge of volume, that our emergency room is overwhelmed. It could be like a minor bus accident where you're just going to have a lot of kids that aren't really hurt, but you need extra hands to help take care of it. And you'd also need some extra administration kind of help, somebody, kind of cover the media, maybe some support help from the social services to deal with the moms that are upset and to help coordinate where all the people who are on the bus, just to keep track of people. The first thing that does is we're not going to reactivate our call list to pull everybody in, that we will get some administrative help. But it'll do things like get extra staffs that are from the inpatient units will come down and help out in the emergency room. And it'll take all the patients that are just sitting in the emergency room waiting for test results or whatever to be admitted, but we know that they're going to be admitted. It'll automatically get them a bed, get them moving, and then their attending physicians will follow what was started in the emergency room. And then get us some extra hands just to help get us over the 1 to 2, 3 hours that we're going to, be kind of overwhelmed to help us get through it. But it's really pretty low-key kind of a thing. When you get to level 2 type disasters, it's a bigger incident. You need more hands. This would be like the train accident kind of thing where you're going to, maybe literally be hundreds of people involved, but you're not expecting it to go on for days. You're thinking that, 24 or 36 hours, this is going to be cleaned up and it's going to be over with. So what you're thinking is you're going to activate your call trees, get in extra staff from home. You're going to also, as they come out into the hospital, they won't just automatically go to the emergency room. They're going to be going to a work pool or manpower pool, and they'll each be given job action sheets so everybody knows what they're supposed to be doing right away when they get there. Some people's job action sheets are going to be simple, like they're going to be escorts. They'll be as they're called that they need extra escorts when patients come into the hospital. That person comes up, they meet with the patient, they stay with the patient through the entire time that the patient's at the hospital, and they take care of that patient to the best of their ability. So if it's a nurse who comes in who's maybe a medical nurse, but it's a red patient that's going to go to the emergency room, they'll do all the stuff that they're comfortable doing, and then there'll still be an emergency room nurse assigned to them to do those other things that they're not. When we'll also open up other areas of the hospital to accept patients. So the red patients will pretty much go to the hospital or to the emergency room. And those are going to be the most critical patients. And then the disaster level uses a 4 colored triage system to identify their patients. So they have red patients who are the most critical patients. Then we have yellow patients who will need some attention, but they can, within the first 2, 3, 4 hours, depending on what, paperwork that you're reading, is how quick they need to be, have that help. Then green patients are basically your walking wounded patients. People that you're going to expect to be discharged, they might have, simple abrasions or lacerations. They're going to get cleaned up, treated, and then sent on their way. And then the black patients, or the expected patients, are the patients who just aren't going to make it. Now, that doesn't mean that they're already dead. It just means that with the system being overwhelmed, it may be not the best use of resources to try to keep them alive, which is a really tough concept to swallow. But when you get to a disaster, sometimes you just have to think that way. So like I was saying, as the patients come in, we'll have a triage nurse at the door. So the paramedics in the field may have already triaged the patients, but each time the patient goes to a different place, they need to be re-triaged. So once they get to the hospital, the nurse there or the doctor who's at the door, they'll look at the triage tag, they'll quickly assess the patient, make sure that, if they were tagged red or tagged yellow, that they're still yellow, that they haven't moved up to a red. And then they'll send them to the appropriate place. So like at Riverside, the reds would go to the emergency room, the yellows would go to the PAR, and the greens would go to the EPL. So once they arrive at the hospital, they'll double check the tag, they'll double check the patient, make sure that it's still appropriate, they'll send them to that area. But upon arrival at that area, there should be a triage nurse in each of those areas to again look at the patient, double check the tag, double check the patient, make sure that they're really appropriate for the area that they're in to get the care that they need. And at any time that they feel that the patient's deteriorating, they can always just rip off a section of the tag, upgrade them, and move them to the other area.
Example of this would be maybe your patient who's a green initially, walking wounded. Maybe they have some abrasions, but really had a head injury and they didn't know it. Patient was alert and oriented ×3 at the time, no problems. And maybe, a half hour later they get to the next stop and the triage nurse reassesses them and says, you're a little confused and maybe we need to up your triage level to a yellow and do a few more tests on you, which could end up turning into a red, but that's what the purpose of it is there, is because little changes can be missed, but as well as the timing of it can, also affect the outcomes.
Yeah. About 13 years ago, we had a major train accident in Kankakee County. The Amtrak hit a steel car, or jumped the rail, hit a semi, I guess, and then that bumped it into a steel rail car, and the train came off the tracks and accordioned. So there was patients that came out of the train on both the east and west side of the track, so the local EMS actually had to set up triage stations on both sides of the ambulance, or on the railroad tracks, for the ambulances to take patients from. And then it's not only can they be treated in the hospital, you can set up surge places. Like St. Mary's had set up a surge hospital for green patients only, right inside Farmer and Fleet. So that kind of took the pressure off of Riverside and St. Mary's. So they were able to get mostly yellow and red patients at the hospitals, and the green patients got to stay out of that, so it decreased the confusion that happened at the hospital. Another thing that they did during that incident is they used the old Tractor Supply store, which had just been emptied a few months before, so it was an abandoned building just south of Farm and Fleet, and it had bays for semi-trucks to pull into, so they actually used that building as a morgue, and they back refrigerated semi-trailers up to it, and then they were able to take the people who had expired into the morgue right there, because if they would have, at the time the county didn't have a morgue, and it would have overran the two small morgues that were at both of the hospitals. So it was really a good idea, and it was lucky that that facility was there, real close to where the accident happened. They could take the expired patients there. They actually stayed there for several weeks while they identified who everybody was and went through that process. And it was really kind of nice that all of that happened outside of the hospital. Then we can move on to a level 3 type disaster, and that's going to be an extended time disaster, something that's going to last longer than 96 hours because the federal government's not going to come in until 96 hours. So what happens then is you have to start thinking, okay, we're going to activate our call trees, but we don't want everybody to come in because after the first 12 hours or 14, 16 hours, we want fresh people to come in to relieve the people who initially responded. So the community, again, has been real good about supporting and doing disaster management planning. The police departments, the ESDA, the fire departments, the hospitals, the universities have all even been involved. One of the things the university's done here at Olivet at the, can you tell me the name of the gym
Burchard.
again? The Burchard Gym. They've have an agreement to where they can set up a surge hospital in Burchard Gym, and we did this several years ago as a training. With federal grant money, we bought all the equipment to set up a hospital, a surge hospital. The agreement is if it happens right here, it'll be at Burchard Gym, but it's really part of a Region 7's surge hospital. So if it really happened anywhere in the South Chicago area, Olivet's said, yeah, you can use our gym, set the surge hospital up. But we have everything is stored at Riverside in a trailer. Everything you would need to have a hospital: oxygen supplies, cots, charts, monitors, suction equipment, you name it, it's all there. And then our trauma coordinator goes through the trailer periodically, rotating out stuff that's soon to be expired. And then, there's pellets of medications in pharmacy that, again, they keep track of and keep up to date to send. And then, again, pellets of stuff down in central supply, the Band-Aids, that kind of thing, so that we can just grab, a couple of straight trucks in this trailer, bring it to the surge hospital at Burchard Gym, get it set up. Obviously, if the disaster first happened, you're not going to try to send people to the gym right away. Well, after 5 or 6 hours, we see it's going to be a big thing, something like happened down in Joplin, Missouri, where their hospital was totally wiped out. If for whatever reason the trailer managed to stay, we could, send our trailer to the gym, get it set up, and have an alternate cure site there.
Right.
We've actually had to use that when one of the local nursing homes had a structural problem with the building itself. The state came in, deemed the building was unsafe, and then they didn't know what to do with all the patients from the nursing home, and it was decided they could use the surge hospital. They didn't use Burchard Gym. They took it out to the county fairgrounds, to the big buildings out there. They set it up, and I think the patients stayed there for about 2 weeks before they were able to get the building back to where it was supposed to be. And it wasn't safe for them to just rebuild the building because of asbestos issues while the patients were there. They actually had to keep them out. So, well, they got it all cleaned up and fixed up. The patients stayed at the fairgrounds. Then they were able to move them back in. So just because it's a disaster doesn't mean it's something big like a tornado or a train accident. It could just be something that overwhelmed their facility and they needed extra help with. Sorry, give me a minute here. And then, of course, the communications is real important, again, when you're having a disaster. How, are you guys overwhelmed? Do we have to open up not only, is this something that's going to be extended time where we want to open it up here, or is this something where we should really just take, if it's, and move the patients up to the south suburbs? The Todd Hospital will be real involved in that, seeing what other hospitals, Morris or Olympia Fields or St. James, if we could be bringing the patients up that way to help with help out in the disaster. Where are we going to move the patients? What kind of patients are they going to take? That kind of thing. And then in the emergency rooms, we have radios where we can talk directly with the pod hospitals, and we can also talk directly with the triage centers that would be at the scenes of a disaster, so that we could be talking to the utilities people and the ESDA and the fire and the police departments to get us an idea of what's going on. How big is this thing? How long is it going to last? Those are the real important things, to just keep up with that communication. And then the federal government's made everybody go through what's called NIMS training, which is basically a training just set to make sure everybody's on the same page when something happens, so that everybody's talking the same language. The fire departments, the hospitals, the police department, the utility companies, the ESDA, the maintenance people, everybody's talking the same. And then if you're going to borrow equipment back and forth, equipment wears out or gets wrecked or gets used up, who's going to pay for that? Those are all part of agreements that you have to think about ahead of time. So the federal government has their hands in. They kind of gave us the money for the Surge Hospital, but then they're also making sure that not one entity is taking on too much of the responsibility, that it gets all kind of evened out.